cases. And I would say that he's the pioneer of intraoperative nerve monitoring in this region. And I'm also proud to say that he's my mentor. And without further ado, the floor is yours, Prof.
Thank you, Mr. and thank you to the colleagues of the experience in doing introduction using the continuous intraoperative nerve monitoring in patients with acute or chronic vocal cord paralysis. So this is the outline of my talk today. I will talk a little bit about the principle of the intraoperative nerve monitoring and the steps that we use in performing the nerve monitoring, and the difference between the intermittent versus the continuous monitoring. And finally, I will come to the role of the continuous intraoperative nerve monitoring in patients with vocal cord palsy. So we are very familiar with recurrent laryngeal that we normally identify visually during the thyroid symptoms. We routinely expose to identify them. But the injury still happens even in the good end. Injury range from 1 to 15%. But in an excellent center, the injury can be as low as 1%. So we are aiming something less than 2%. So what is actually intraoperative nerve monitoring? So this is a system that we use to verify functional integrity of the recurrent laryngeal. So there are many ways of doing this, using the different types of electrodes. In the past, a lot of people were using the intramuscular placement of the electrodes, either endoscopically or through the trichocerebral. But more recently now, something less invasive, we use a surface electrodes, where it is placed at the behind the trichode area, and more recently that it is attached to the endotracheal tube. And the endotracheal tube base of this is very important because this is easy to set up, and it is not in the area actually has very good contact with large area of the vocal. So this is the principle of the endotracheal tube ENG. When you stimulate the vagus or the recurrent laryngeal action, or the impulse will be transmitted down to the vocal cord, that will cause movement of the vocal cord. And the movement of the vocal cord will be picked up by the surface electrode, and this will be converted into electrical impulse that will be shown on the monitor. So if you have a complete circuit, that means the nerve is intact, the vocal cord. So this is the conventional method. We use the EMG EP tube. This was fixed after we confirm the position of the electrode. It's very important that the electrode, the loop segment, must be in contact with the vocal cord. So usually I tend to put a little bit deeper, because when we extend the neck, it might move. But there is limitations of using the endotracheal surface electrode. You need a very good contact between the electrodes and vocal cord. So you may need to use a bigger tube compared to the usual. You have to verify, you have to make sure that it is in the correct position. So you really need to work well with your anesthetic and make sure that you are in the correct position. But another problem during the procedure, especially if you are dealing with large, the rotation, the displacement, or when you maneuver during the procedure, might cause the tube to move in position. That will affect the reading of the EMG. So this is the thyroid calculation method introduced by Professor Chang from Taiwan. So we use normal EP, but instead of using the surface electrode, we use the needle electrode. Okay? So the needle being inserted at the thyroid lamina on both sides. And then the principle here is more of the electrical conductivity rather than mechanical movement. So the best place is to understand, the best place is really on this area, the area of But there's also limitation of the electrodes. It's a bit difficult if you're using a small incision or mini training, or you are doing a mid-back procedure. But you need to dissect through the calculation, the parameter, in order for you to be able to insert the needle. Or if you are doing endoscopic thoracotomy, it's quite challenging to insert the needle into the calculation. I found that in some elderly people have falsified calculation, found it a bit difficult to insert the needle. So what about the advantage? Yes, it does have advantage. The EMG may not be suitable to certain applications you have spectroscopy. So you may have to change the tube if you want to use a standard EMG. Or in some cases where you have the fracture that's severely compressed by huge pressure, you cannot use a standard size. You may want to use a smaller EP. The smallest EMG EP is 6.0. So if you are going to use 5 or 5.5, then you can use the standard EMG. I used once in a child, 6 years old child with cancer. So we were using size 5 tube in that case. So we used the Taiwan for the tarot calculation in that case. There may be situations where you were not using the net monitoring, but intraoperatively you found that the net is compromised. Then you may want to use this rather than changing the EP tube, then you can just proceed to the tarot calculation. So these are listed as 4 steps because it's the V1, R1, R2, V2 is the laryngoscope and the post-op laryngoscope. So this is the V1. What we do in the first step is that we dissect the carotid surface in here. You look at the integrity of the nerve. We get good conduction of the nerve, then we know that the nerve is intact, not involved by the tumor. Or you may be able to find the non-recurrent laryngeal nerve. The type 1 is the type 2A, non-recurrent laryngeal nerve. Next is to look where roughly estimate where will be the we call it mapping. Okay, so you use a higher amplitude, higher stimulation, 2 to 3 milliampere, and you sweep around from medial to lateral or lateral. Once you get the reading, then you will expose the nerve, and then once you identify the you put the lower stimulation 1 milliampere. You may also see the branching or extralaryngeal branching, and you can stimulate the branch to find out which one is the sensory which is useful. After having done the surgery, then you will stimulate the recurrent nerve. So this is the intermittent method. Then you stimulate the nerve and to find out the integrity. But the most important is the vagus nerve. It's the final step to make sure that the circuit is complete. So what you must do is that you must stimulate above the level where you dissect the vagus. Because if it is absent, it could be the injury anywhere along the surface. It could be the vagus nerve itself that you have already injured, or the recurrent laryngeal nerve where it could be behind the brachiocarpal trunk, or the subclavian artery, or even at the balance region. So absence means there is injury somewhere. And if it's present, then you can say this. And not only so the difference between intermittent nerve monitoring, because if it's just an intermittent stimulation, you don't pick up when there is stretch injury or compressed injury that might happen during the procedure. So at the end, when you measure the V2 was already low, then you know that the injury, but it's too. But the continuous intraoperative nerve monitoring is a continuous stimulation. So you will get the reading all the time. So you will see if there is any compression in the nerve or traction injury, you'll see the amplitude. So it is a real time. Important slide for those who are using the nerve monitoring, especially the continuous nerve monitoring, but I will try to see if my next slide. So we come to the first group of patients, which is acute nerve palsy, which is a primary nerve injury that occurs during the surgery itself. Okay, the first one is that you get a reduction of amplitude to less than 50%. So it goes down to less than 50%, but more than 100, so we feel okay. Latency is less than 110. And then this is type 1C, you don't get vocal cord palsy. Or you can have double event, have increase in the latency, in drop in the amplitude. Still, not more than, it doesn't drop more than 100, less than 100 microvolt. In this case, you still don't get vocal cord palsy. So what is most important is that when you're using the nerve monitor, never allow the amplitude to drop to less than 100. If starting off more than 500. If you get anything that's going down, it's probably due to the reflection and compression to change your frequency approach. Okay, this is very important. If you have a sudden loss of amplitude to less than 100, remember earlier, more than 100, here is a less than 100. If you get it less than 100, regardless of the latency, so the type 3A, this is the way you have a sudden drop. It usually is due to the trauma, instrument, or energy device, or you accidentally transact. So what you can do at this time is to provide the patient with steroids that dexamethasone and then wait for the recovery. You might or might not recover. So what type of recovery? If you will get amplitude recovery for more than 50%, then you will be happy because there will be any pulse. But if the amplitude recover but less than 50%, you still have a 100% chance of vocal cord palsy. So in a sudden drop like this, whether it recover to less than 50% or don't recover at all, then you will get no palsy. So you should start thinking of immediate radiography, provided your opposite side is working or the nerve is fine on the opposite side. So if you have a complete loss of the signal due to the transaction of the, you know that you already transacted, then you might as well push to the radiography and then the nerve immobilization. So another group of acute nerve palsy, now you have a gradual loss of signal. You don't see this in intermittent nerve monitoring, but you can see in the continuous nerve monitoring that the amplitude goes down to less than 100, regardless of the latency. So usually it's due to the traction injury or compression injury. It is reversible, so you have to change your strategy. If it's still going down, let's do some steroids. So what type of recovery you can get? If you recovery more than 50%, just like at 3A, you don't get vocal cord palsy, just like this. Okay, but if your recovery is less than 50%, there's a chance, 30% chance that the vocal cord is not palsy, and 70% will be palsy. Different from the type 3A, when it recovers to less than 50%, still 100% palsy. But if there is no recovery at all, then the patient will have 100% vocal cord palsy. So in this case, you will probably decide to go for laryngoplasty. So the take-home message is that use continuous intraoperative nerve monitoring rather than intermittent in order to detect compression infection injury. The initial amplitude should be more than 5. Never allow the amplitude to drop below 100. The type 3A segmental injury is very difficult because the chances of recovery is very low. So if you have type 3A, think about the risk reduction surgery. Maybe you want to end up subcortical thoracotomy on the opposite side or bring your surgeon machine. So you can do stage procedure if you are planning for total thoracotomy, just complete the hemiectomy and come back for the completion. And if the opposite nerve is fine, then you can think about doing the surgery. But for type 3B, you have a better prognosis that the nerve might recover. So in most situations, we just care for the nerve to recover. Okay, so the last group is the chronic nerve palsy. The patient already developed nerve palsy prior to treatment, either because of previous thoracotomy or because of stomach immunity, or in some cases, a very rare situation, get into immunity. So in this patient, they do have unilateral vocal cord palsy. So further surgery will risk put the patient at risk of having bilateral vocal cord palsy. So if possible to delay the completion surgery, just try to delay to 6 to 12 months and wait for the spontaneous recovery. You can look at this like evidence of laryngoscope or the pre-operative EMG. Just share with you a few case scenarios. First case scenario, 15 years old girl who had left me, came back, the histopathology came back as acute cancer 2.5 centimeter, and the patient had left vocal palsy. According to the surgeon, the nerve was intact, but the function became faulty. So this girl belongs to the intermediate risk group, but this is the adolescent differentiated cancer. So we should be aggressive in treating the patient with total thrombectomy and possible intersection. So what was done to this girl because of the vocal palsy? We just wait, and after 1 year, the voice came to look at the voice, the vocal cords. So we think that could be neuropatia. But at this time, she presented with suspicious left brachial leakage, and because of the adolescent differentiated cancer, we decided to proceed with surgery. And intraoperatively, we found a very good amplitude on the left palsy side, previously palsy side. So we proceed with completion thrombectomy with left neck extraction. We didn't do any laryngoplasty because the voice was recovered, and we didn't do nerve regeneration as the positive on the left. The second patient is a 42 years old Sarawaki who presented left vocal cord palsy with multiple lung metastases to the SNA and polyplasm. So we plan for total thrombectomy with the patient. So intraoperatively, we have a tumor encasing the nerve when we measure the amplitude was 0, there was no signal at all. That means the nerve is not functioning anymore. So we proceeded with total thrombectomy to perform laryngoplasty and nerve reinnervation using the results by police. The last case is a 42 years old lady, 3 years history of change of voice. She presented the last 3 months to seek medical treatment, and that time the laryngoscope showed left vocal cord palsy. They did a CT scan and found left upper growth, and the node was benign. So we proceeded with hemitolectomy. We found the nerve. We preserved the paranormal nerve on the left side, and there was constriction just above the nerve. And when we cut or release the constriction, the amplitude improved from 1,200 to 1,400. So we think this is a problem exposing the vocal cord paralysis. Because the patient still have vocal cord paralysis, we do injection laryngoplasty, but we do not need to do nerve anastomosis or innervation or dissection. This is benign condition in the nerve. So the take-home message is that the continuous intraoperative nerve monitoring starts to reduce the possibility of the bilateral vocal cord palsy because we can monitor the function of the opposite side. It helps to decide intervention on the palsy side. Either is it detectable amplitude, then you don't need to do anything, but if it's still palsy, clinically, then you can do laryngoplasty to improve the voice quality. But if you have a good amplitude, then you don't need to do anything. If you have no amplitude, then it's like that. Nerve can be sacrificed. You can do laryngoplasty. So in summary, ladies and gentlemen, the continuous intraoperative nerve monitoring during the is very essential, especially when you're dealing with complicated. In acute vocal cord palsy, the types of injury will determine the outcome and intervention needed in the same setting, and prevention can be achieved by using the continuous intraoperative nerve monitoring. In chronic vocal cord palsy, the information on the function of the palsy site will be helpful in deciding the kind of intervention that we are going to do at the same time. Ladies and gentlemen, thank you very much. Please stay at home.